Thanks for listening to the Granite List.Live. Today's episode is brought to you by Connect Healthcare Collaboration, where benefits marketing meets clinical advocacy to drive effective employee engagement. This is the Granite List.Live, where we explore all things human capital and employee benefits related. I'm your host, Sally Pace, and today we have our dear friend, Dr. Jessica Lea, who is the CEO of Tria Health, on for a topic that is saturating the employer-sponsored health plan space, the landscape of GLP-1s for employers, and we're going to talk about how to navigate what's next. Jessica, thank you so much for being on.
Well, thank you for having me today, Sally. This is definitely a timely topic, and I don't think it's going to end anytime soon.
Unfortunately, I think you're right. Just setting the stage, let's talk a little bit about Tria Health. You all provide pharmacist-led chronic condition management across the board. Why is pharmacist oversight so important in the chronic condition management space?
Tria Health has been in business since 2009, and our partnerships are with self-insured employers. And what we do is put the pharmacist in the role of helping patients navigate how to ensure that their medications are appropriate, safe, and effective, and they're doing what they're intended to do. Alongside their primary care physician, we're really hoping that we can maximize and improve outcomes for the members, which then obviously results in, hopefully, lower costing, long-term use for those individuals who are on the employer health plans. And, the GLP-1 conversation is just a very good illustration of what we do at Tria Health. We've been managing GLP-1 medications for years. They've been on the market for 10 years in the diabetes space. And so this whole new landslide in the last 3 to 4 years has really been around this unique disease state, obesity being found as a disease state several years ago, or being classified as a disease state several years ago. Many employers are now in the world where they're being tasked with what to do regarding these costly drugs who have efficacy. These drugs are working, and that's the challenge, is that we see the value clinically, but how do we manage the costs? And so what pharmacists are really doing, and we're seeing the evidence over the last 2 years, of ensuring that if these medications, which are costly to the employers, if members are getting access to them, ensuring that these medications are working appropriately and that you're getting the intended results, and really protecting the plan's bottom line, which is dollars. And pharmacy costs are continuing to be a conversation and rising part of employers' spend.
Absolutely. That is so spot on. And of course, like you said, that GLP-1s are incredibly expensive. So from your vantage point, what are some of the main challenges employers are facing when they're deciding whether to cover GLP-1s or not for their employees?
Yeah, and I think we're continuing to watch the trends on what employers are doing. But, the reality is that because these drugs are so effective in the lowering of obesity, and we also can even talk about all the other disease states that they're really improving clinical outcomes for members in their health long term. The challenge is that one, some are covering them and some are not. And you're obviously wanting to identify and compete in the benefit space, because we're seeing that employer surveys are showing people are saying this is just as important in terms of access to these medications as getting PTO and pay, which is crazy, right? Like, that's interesting. So they're trying to be competitive. They're also trying to be innovative, right? It's a situation where it's not just like a small batch of people who would be eligible or have access to these drugs. We're talking about a bigger population. So clinical innovation, trying to stay on top of the medical development and how we can better treat the obesity epidemic in the United States, is something that's on the employers' minds, because obesity is tied to so many other chronic disease states. But then what's happening is these are becoming like the top 10 pharmacy spending for employers, and that's not sustainable. So it's really an economic dilemma for these individuals who are trying to say, I still want to provide good and benefits and employee access to the right medications for the right people, but this isn't sustainable, and we can't continue to do this because it is breaking the bottom line for us.
Absolutely. So that is a dilemma, and and employers are kind of being tasked with weighing the high cost of those drugs versus the need to support employee health. So what all are you seeing from that front?
So I think the biggest important thing to do when it comes to deciding to move forward and allow access to these medications is to really understand that it's important to have not only some guardrails in place for how to ensure that the right patient's getting the right drug, because we do know that the world of obesity becomes not just a disease state conversation, but it can be and historically can be questioned about vanity too, right? And I think we're getting more educated about the role of obesity and inflammation and metabolic health in other chronic diseases more and more. But for employers, they're saying, I can't allow 40% of my population who may be eligible to have access to this because I can't afford that based on the current pricing models, which we can get into in a little bit. But I want to be able to give people who truly need it and want it access. But I want to make sure that if they're doing that, they're doing what they're supposed to do. And these aren't magic pills, right? We know if you look at studies where we're seeing the 17 to 20% reduction in weight for individuals who are taking these medications, those are controlled studies where they're doing all the other things too, including moving their body, getting access to the right nutrition, ensuring that you're supporting your overall metabolic health long term. Because we know that in order to make this a successful journey for people, obesity isn't just a medication conversation, it's behavioral understanding, why people have the relationship they do. So there's a mental health component to this. There's a change in lifestyle and understanding how to ensure that you're accessing the right foods to fuel you. But let's also say, like, this has to be practical for people. You can't put them on like a 800 calorie diet and then put them on these meds and say, now you have to live your lifestyle that way. This has to be something that's about a long-term journey for these people. So being able to give the employee all of those things plus control costs, it's really complicated and it's really hard for employers because it seems to be that every day something's changing too, right? And costs are changing and access and release of new medications is changing. So this is just a rapidly changing environment. And for employers, they can't just sit on it. They have to make a decision. And it's not a year problem. It's not solving it for 25 or 26. It's how can we create a long-term strategy for that?
Exactly. And I want to shift gears a little bit from just the employer down to the employee level. Again, unless you live under a rock, you have noticed this massive uptick in the direct-to-consumer GLP-1 medication wave. And so, that is another layer to this issue that employers and employees are dealing with. So thinking about that direct-to-consumer model that kind of omits that clinical oversight, how are you advising plan members about navigating that? And what are the things that employers and employees should be looking for?
Yeah, let's celebrate a little bit that we're finding ways to create better cost and access for members. We could argue, is this the perfect way? But I do appreciate that we are now coming up with better solutions, especially in the United States. We hear a lot about what the access and cost is in other countries. So having some access to direct to consumer costs is great, as well as having some of these cash pricing access and coupon programs. But having direct access to a low cost net is really good. I think the challenge for employers, and this kind of goes to this concept of no disease states in a silo, is that an individual who may be accessing direct to consumer pricing because they don't have access to it through an employer, or that access to the direct to consumer is lower than their employer costs or whatever. The challenge is one, they may be accessing those drugs in terms of the prescribing patterns from physicians that they're also not aware of their other chronic conditions. So, once again, these medications are not perfect. We know they have tons of side effects. They affect other disease states in many ways. And when people start to lose weight, we see that people are having more and more problems with their hypertension, meaning their hypertension's getting better, but they're still in the same dose. And now they're having side effects related to that. So this silo of direct to consumer worries me because how are those people being managed? All the physicians and all the disease states being considered when it comes to that. And then from the employer perspective, they're losing access to information. about these individuals as well. And we have historically helped make decisions regarding plan design and medical access and costs related to having all the information that's going on in your plan right then and there. So this whole exchange of information is of concern to me. And then just having multiple providers who may or may not be aware of what's going on, because some of these individuals who are accessing a direct to consumer also don't want anybody to know they're on these drugs too. So we've got a lot of challenges for the employers. And I think the other thing is some employers want to be a part of providing access to these meds in a controlled way. And just having them go direct to consumer can be challenging for the employers to understand long term what we see with these drugs coming down the pipeline.
So then what is the solution for employers who are looking for a comprehensive obesity management program?
So at Tria, we are partnering with many employers, especially in the last couple of years, to really help them try to access the lowest net cost on these medications. So ensuring that these members are getting the lowest out-of-pocket cost for them that the employer sets forth, but the employers are not paying the $1,000+ a month on their cost share as well. But the other important thing that I think we are providing for our employers is the ability to provide not only the conversation about maybe guardrails, making sure that the right person's getting it, not the person who's going for bikini season, but the person who truly needs access to these medications. But then they're not just taking the meds, they're getting comprehensive support long term. And the other thing is, they have to kind of have individualized comprehensive support. And that's what our pharmacists, health coaches, and dietitians are doing for these members that the employers appreciate, because we're walking alongside that individual, seeing where they're at, what they have going on in their whole situation. It's never just obesity. There's usually multiple other conditions and challenges you're dealing with, and walking alongside them on that journey to continue to provide well-educated individuals who will continue to move towards the direction of solving some of their metabolic problems rather than just taking symptomatic medications for metabolic issues.
We haven't released it yet, but our 2026 outlook for the Granite List talks about this need, this demand for personalization. And I think you all live that out every day, and you just spelled it out with having that pharmacist-led conversation around chronic condition management. And you kicked this off by saying this is not a 25-26 issue. It's going to be around for a while. So can we kind of wrap up our conversation by talking about what you see as the future for GLP-1s?
Well, in the first few months of the year, actually, it's only a few days.
Days, Jessica, days.
It must have been a long week or so. In the first few days of January, we've obviously had multiple notifications regarding the release of the oral semaglutide tablet. And the oral is probably what's most on the early horizon for additional compounds in the marketplace. And the oral changes it a little bit, right? Because we know some people have needle phobia, some people have difficulties taking those things via injection. So the access to the oral medications is going to be important to pulse and recognize. What I don't know yet, but what some people have a hypothesis on, is that the oral is going to increase the utilization, and we don't know that yet. I think it's important for education-wise and people to understand that the oral is daily. And the oral has a lot of stipulation in order to get the best effect from these drugs. You have to take it in the morning, 30 minutes prior to any other medications. There's all kinds of certain restrictions. So it can't just be taken and move on. Like, you can't just pop it in while you're taking all your vitamins in the morning or whatever you're taking. It has to have some very clear parameters on how to move forward. So there's uniqueness to these drugs, even though the utilization and the cost may be closer to more potential uptick. I think that the challenge for the new ones coming out, or the opportunity for the new ones coming out, is that we're going to see triple agonist type medications. These drugs are only going to get better at the lowering. So right now we're seeing, 17 to 20% lowering on the current molecules that are out. The triple agonist is seeing more than that. So we're going to see more effective medications. We're also going to see medications that begin to hopefully preserve some of the challenges we have with these GLP-1 medications, which is that we're having some issues with maybe some nutrition deficiencies and maybe some muscle loss because your body doesn't discern whether to lose muscle or fat. And we're seeing potentially some things that they're testing that try to bring in additional actions for these medications, which will preserve muscle. But who knows what these are going to cost, right? Because that becomes the $1,000,000 question. And the other thing we're going to see, Sally, more and more and more types of disease states outside of just obesity that are going to be explored for these medications, because this isn't just a weight loss drug, it's truly a metabolic change category. And we're seeing the way that it affects inflammation, and we're seeing other disease states where those, or the cornerstones of the disease state, these drugs are being effective for that too. So this is just the beginning, and we're going to continue to have multiple medications, and maybe that will help us with cost as well, as we look towards also finding additional ways in which we can decrease net cost for employers and members.
And I suspect you and I will have multiple conversations about this throughout the year as this plays out. So I thank you so much. You have been a wealth of knowledge in the first few days, not weeks or months of the year. It does feel like January has come in with a bang. But Jessica, thank you so much for what you and your team do in helping that whole person chronic condition management. And the team at Tria Health is fabulous. We are so proud to showcase you guys on the Granite List. And thank you for being on today's show.
Well, thank you so much. And we appreciate the opportunity to share what we truly feel is really, really important in the healthcare landscape.
Absolutely. Well, thank you for listening to another episode of the Granite List.Live.
Thank you for listening to this episode of the Granite List Live. Access our entire library by visiting your favorite podcast venue or subscribe on our site, thegranitelist.live.